This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. Copyright 2018, all rights reserved. My name is Shauna Strickland. I am a registered respiratory therapist, asthma educator, and Associate Executive Director at the AARC. I welcome you to today's presentation, a comparative analysis of ideal body weight methods for pediatric mechanical ventilation. Upon completion of this AARC webcast, participants will be able to identify the research question of the study, identify the study design, discuss the main results of the study, and discuss the implication of the study on patient care. I am pleased to welcome Dr. Michael D. Davis. Dr. Davis is a registered respiratory therapist and assistant professor in the Division of Pulmonary Medicine at the Children's Hospital of Richmond at VCU in Richmond, Virginia. Dr. Davis is currently funded by research awards from Protexcom, the Children's Hospital of Richmond Research Foundation, and the NIH, and has no conflict of interest with regards to this presentation. I disclose that I am a paid employee of the AARC. Brand names of products and or medications may be mentioned only as examples of technology. Any use of brand names is not in any way meant to be an endorsement of a specific product, but to merely illustrate a point of emphasis and to provide information and education regarding the availability. Dr. Davis, welcome to the program.
Thank you very much, Shauna, and thank you for the warm introduction. It's my honor to be here and present this today. So, with regards to today's presentation, I always like to have an overview. We're going to go over a background on the topics that are presented in this manuscript by Bill Hars et al., and then go into methods, talk about the study design of the study conducted and reported here, the statistical analysis used, and then go over the results, and then discuss those results and discuss how to interpret them, talk about some study limitations, and then talk about conclusions that can be drawn from this manuscript, and then open the floor to questions. So the background that led up to this is that when determining tidal volumes to deliver to patients who are mechanically ventilated, historically those are guided by the patient's weight. And for the past several decades, it has been recommended to use ideal body weight as opposed to actual body weight in order to determine tidal volumes to deliver to mechanically ventilated patients. And that is for patients of all ages. And in fact, even in the most recent summit on pediatric ventilation last year, at the end of the year in 2017, under their recommendations for invasive ventilation, they include for tidal volume to keep the tidal volume less than or equal to 10 milligrams per kilogram of ideal body weight, again indicating that you need to calculate ideal body weight in order to determine the appropriate tidal volume. However, most existing data used to support ideal body weight formulas used to guide mechanical ventilation were developed from adult cohorts, not pediatric cohorts. And indeed, no gold standard method for calculating ideal body weight exists for any age, but particularly pediatric patients. But several methods are commonly used. And this is what led the authors down the road to investigate the study they report here. So the study design they came up with was a descriptive study. And descriptive studies are different from randomized control trials in that their goal is to simply describe differences between different things. It doesn't have to be hypothesis-driven. This particular study does not report a hypothesis. It can be, but again, it is much more descriptive and observational than interventional, just describing data that already exists. This is a retrospective descriptive study, which is pretty common in descriptive studies, and that simply means that all of the data evaluated here existed prior to the conduction of the study. So they went back. This is typically done in a chart review, as was done here. So this, again, is a descriptive study of data that already existed. The aims of the authors were to compare 3 commonly used ideal body weight methods and assess differences between them and the actual body weight of pediatric patients. They were looking back at data from pediatric patients and looking at their actual weight and then using 3 different methods to calculate ideal body weight for these patients and compare between them. And a key thing here is the assumption that a 10% or greater difference between actual body weight and ideal body weight is clinically important. And the reason that that is considered clinically important is that because we use weight to determine tidal volumes that we deliver, a 10% or greater difference between actual body weight and ideal body weight would translate to a 10% or greater difference in delivered tidal volume. And a 10% or greater difference in that would be considered significant. So the methods they used for their study here, they looked at patients between the age of 2 and 20 who were mechanically ventilated in a medical surgical pediatric ICU. So that was the inclusion criteria. So exclusion criteria, patients that couldn't be enrolled were patients who didn't meet this, so younger than 2, older than 20, not mechanically ventilated, or not in that ICU, and also patients with scoliosis or congenital heart disease. And these are pretty common rule-outs when you're trying to evaluate methods in a data set, because these syndromes are often associated with differences in anatomy, which makes the subjects with these syndromes hard to compare to other groups. So they excluded those, and that's not uncommon. This study was approved by the IRB, which is mandatory, and the IRB granted waiver of consent for this study. And what that means is that they did not have to, the investigators did not have to obtain consent from all of the subjects to look at their data. This is pretty common with retrospective chart review type studies, but again, that waiver of consent has to be granted by the IRB after approval of the study. As far as enrollment, they enrolled for a 2-year period. So they looked back at the charts for 2 years between 2014 and 2016. During that period, they identified 58 subjects that met their inclusion criteria. So that's what they enrolled for the study. And so what they did for the study was that they calculated ideal body weight using 3 different methods for each of these 58 subjects based on their reported actual weight and actual height in the chart. So the 3 methods they used are the McLaren-Reed method, the Moore method, and the body mass index ideal body weight method. The McLaren-Reed method is a growth chart method where they determine the 50th percentile of weight based purely on the patient's height. The Moore method is another growth chart method where they determine ideal body weight by looking at the percentile of height of the subject and matching that to the percentile of weight. The body mass index ideal body weight method takes the 50th percentile of a subject or a patient, compares that with age, and then multiplies that by height. So they did all 3 of these for all 58 subjects, and then compared these values with their actual weight as it was reported in the chart. And then they calculated the percent difference between the two, which they called the percent error, meaning that if they had used the actual weight to determine tidal volumes, the percent difference between that actual weight and the ideal body weight would have been an error in tidal volume delivery, hence the term percent error. Once they had collected this data, they used what's called Blant-Altman analysis to analyze, to perform statistical analysis on their data. This Blant-Altman analysis is a technique that was developed in the 80s, and it really is ideal for studies like this because it is a statistical method that is used to compare measurement techniques. So like in this, comparing different ideal body weight techniques and then comparing them to actual weight is specifically what this analysis is designed for. Within that, they conduct two other methods of statistical analysis. One is the Wilcoxon signed rank test you'll see in the manuscript. And that test is very similar to a student's t-test, which is the most common analytical test performed. And this is for comparing between two groups. So actual weight to ideal body weight would be an example that they did here. And the reason they use Wilcoxon's signed rank test instead of student's t-test is that this data set was not normal. The next slide, I'm just going to briefly go over normality with regards to data. But when you see Wilcoxon's signed rank test, you can just go ahead and assume that you can think in your head that is a student's t-test. It just means the data is not normal. Also, the Kruskal-Wallis test they used. This is really very similar to another very common test called ANOVA, or analysis of variance. And ANOVA is probably the most common statistical test for comparing multiple groups or multiple variables. However, again, with non-normal data, you have to use a slight variation on that test. So the Kruskal-Wallis test, when you see it, you can just think, okay, this is an ANOVA, fairly normal test, but clearly the data set wasn't normal. Brief overview on normality. So if a data set is normal, it means it will plot on a nice curve like you see at the top of this slide. It means the majority of the data is in the center, and that the data points that fall outside of the center do so evenly and decrease as they do. However, non-normal data tends to be skewed, so it pushes that curve either to the right or the left, as you see in the bottom of this slide. And when you have non-normal data, because it is pushed away from the middle, you have to use slightly different analytical techniques, and you report the data differently. With normal data, you report it as mean plus or minus standard deviation. However, with non-normal data, you report it as median plus or minus interquartile range. And this is important, and this is important particularly to the study we're discussing today. And I've created a small example here. This is all made up data you see on this slide. But this is an example of a non-normal data set, because you see a bunch of data points pushed all the way to the left and then one all the way to the right. Nothing falls really in the middle there. If you were to report that in a mean, meaning again that average plus or minus standard deviation, because of this one data point way up near 250, if you reported the mean of this set, you would get a number around 50. And this standard deviation range from 0 to almost 90. When we report that, that's a bit misleading, because as you see when you look at the actual data points here, most of the data in this made-up set are down around 25 or 20. But that one outlier up at 250 really pushes your mean value off. So if you were to report this as 50 with a standard deviation, again, between 0 and 78, that would be misleading. However, when you report it as a median, plus or minus that interquartile range, what you do is you push down, so the median is again that middle set right there. So the median of this data set ends up being about 21. And then the interquartile range, what that means is that you cut off the top and the bottom quarter, those extreme far out variables like that 250, and you end up with numbers that make a lot more sense. So when you see numbers here that say a median of 21 and interquartile ranges of 12 to 30, in your mind you can see that there are a bunch of dots sitting down there in that range on the chart. Whereas if you reported that with mean, it would be a little bit more confusing. So again, just to show those together, you really can see a big difference when your data set is not normal, like this one, this example set, whether you reported mean or median. So when you have non-normal data, you have to use special analytical techniques to analyze that, and you have to report it differently as median instead of mean. And that's what you see here in the results here from the study. So this table, the top of this table are the descriptive results, so just the describers of the descriptors of the group they were evaluating. So you have the age, the weight, the height, just data there. And all of it is reported if you look at it with that IQR and median. So median and interquartile range. And that's what the number under results is, and then in parentheses next to it is the interquartile range, the median interquartile range. The bottom of that table is the first set of statistical results from here. And that demonstrates that this is comparing the ideal body weight methods to actual body weight and also to one another. And they report that using that Kruskal-Wallis test, again, that ANOVA test for non-normal data, there was no significant difference between these groups. The McLaren method, the Moore method, the body mass index method, there was no difference between them. However, if you look here, for each one of them, the difference greater than or equal to 10% you see there, each one of those groups, more than half, so 55.7% for McLaren method, 56.9% for the Moore method, 51.7% for the BMI method. So again, more than 50% for each method had a greater than or equal to 10% difference between ideal body weight and actual body weight. So there's a big difference between ideal body weight and actual body weight with each method, but the methods themselves didn't have any difference. And we'll talk about what that means in a minute. And these are Bland-Altman plots on this slide here. And these are a little bit confusing to look at first. And it's a really nice thing. I've cut and pasted in a quote the authors put in the manuscript that I really appreciate because I feel like it explains them pretty well. We'll go over them a little more detail later, but this quote says here, the mean biases were 2.7, 3.9, and 3.2 between each of those methods. The McLaren-Reid method was 2.7 versus actual body weight. The Moore method was 3.9 versus actual body weight. And the BMI method was 3.2 versus actual body weight. And what that means, so those numbers are in kilograms. And that means that on average, for each patient, the McLaren-Reid method was different from actual body weight by 2.7 kilograms. And the Moore method, 3.9 kilograms, and the BMI method, 3.2 kilograms. So that's saying that across the board, those were the average differences, those mean differences. However, once patients got higher than 25 kilograms, those differences got much larger. And I'll zoom in on that in a minute, but that again explains that we talk about means. If you just average this out, you get a fairly small difference of around 3 kilograms between actual body weight and ideal body weight. But when you analyze the data correctly and look at it for the non-normal data set that it is, you get this big difference. So what does this mean? Let's simplify this down and sort of talk about this in more normal clinical language. So the first thing, as I said, that these results report that are really important is that these three ideal body weight methods were not different from one another. So it doesn't matter which one you use. They're all pretty similar. The second thing of note here is that all three ideal body weight methods were very different from actual body weight. So again, it really does matter to use ideal body weight because all three of them were different from actual body weight in this group of 58 subjects. But the first really important thing, as I mentioned earlier, is that in this cohort of only 58 subjects in one ICU, more than half of the patients would have had a clinically significant difference in applied tidal volume if actual weight had been used instead of ideal body weight. So again, more than half of patients would have had tidal volumes that were off by more than 10% if actual body weight had been used instead of ideal body weight. And it really does illustrate the importance of using ideal body weight in order to calculate your tidal volumes. But here is those Bland-Altman plots and an explanation of those. So now I've stacked them on top of one another, and I'll explain what they mean. So the top is McLaren-Reid, the middle is Moore, the bottom is body mass index. In each one of these graphs, it is compared to actual weight. So when you look from left to right, you go from low body weight to high body weight. So on the left, where you see those tight clusters of dots together, those are people with lower body weight. And on the right, as the dots start to spread out, those are patients with higher body weight. From top to bottom on the axis there, what you're looking at is differences from one another, meaning differences from ideal body weight to actual body weight. So on the left, where those dots are clustered really tight together, there isn't much difference between actual and ideal body weight. But as you move to the right, those dots start to spread way out. And on the end, some of those dots are really far away near the top of the graph. And that's illustrating that as your patients get heavier, the difference between ideal body weight and actual body weight becomes more significant, right? So the cut point here, talking about greater than 25 kilograms, which is within that red circle on this slide. Once you go above 25 kilograms, the percent error increased drastically. The point that the highest dots on these graphs are above a 40% difference between actual and ideal body weight. So if you're using actual body weight in these subjects, you could be delivering 40% greater tidal volume than you should. Of note with this, and there was an editorial about this article to stress this point by Rader et al., who comment that we are currently in the midst of a well-documented national and worldwide obesity epidemic with dramatic increases in childhood obesity over the past 2 decades. So we're going to see more patients on the right side of these graphs reported here. And not using ideal body weight to calculate their tidal volumes puts us at risk of delivering drastically incorrect tidal volumes to them. So, as with any study, there are limitations. And one of the biggest limitations to the study reported here is that it was a retrospective study. And that's something that is just built in. All retrospective studies have some inherent limitations. Mainly that is based on the fact that they are dependent upon past reporting. So if you're looking at data that has already been entered into the record, into the chart in the past, you don't have a great way of validating what you're looking at. So you're held to whatever chart content there is. So if data's missing, you can't go back and get it. If you want more detail, for instance, in this study, the authors mention that mechanical ventilation settings they would have wanted to evaluate weren't included in the chart. And you can't make that happen when you're looking retrospectively, so you're limited there. And you also have to be aware that you're limited with accuracy, that any charting errors that occurred in the past, you're not going to be able to differentiate. So any errors that are in the chart will be included in your data. This, again, you just can't change things. You also can't affect the intervention. You can't, measuring techniques in this study were an example given by the authors that ideally you would want to make sure that all of your subjects were being measured identically before calculating ideal body weight in a study like this, and they don't have a way of doing that. So they're assuming that everyone was measured the same, or that any differences in measurement would sort of fall out during data analysis. Other limitations to this study are based on the size of it. Although 58 subjects is certainly large enough to report and publish, and it doesn't weaken the value of this study, a larger multi-center study would be more impressive, as certain policies and procedures and even patient populations vary between centers. And involving a multi-center study just gives you a more robust population of data. Same with, in this study, it was not only in a single center, it was in a single ICU, one pediatric ICU, and if you increase into other ICUs, you're more likely to see more diverse patients and also just more diverse practices, which helps strengthen your study. And a final limitation to discuss here is that there were no patients less than 2 years old. Now that's not a huge limitation, but it is mentioned by the authors, which I appreciate. And it does just say that we are limited to they are limited to what they looked at. And this was clear in the inclusion and exclusion criterion. So, in conclusion, the author's conclusions are, in the manuscript, are that several ideal body weight methods produce similar values for pediatric patients. Again, they looked at only 3, the McLaren-Reed, the Moore, and the BMI ideal body weight methods, but there were no differences between those methods. So you can feel pretty confident if you're using one of those methods that you're getting reproducible data that you can compare to one of the other ones. The other thing that they conclude, obtaining height measurements and calculating ideal body weight can help deliver appropriate tidal volumes to mechanically ventilated patients. And this is especially important in patients greater than 25 kilograms, which is a very interesting and powerful observation they've made. And as far as conclusions beyond that, and these are conclusions of mine, as reviewing the article, although limitations are pointed out and further research is warranted, a multi-center study in a larger population, the evidence here, I think, fully supports the notion that ideal body weight should be calculated and used to guide mechanical ventilation in pediatrics in current practice, that whether this study could be improved upon or not doesn't take away the really convincing data that and results that they have presented. With that, I'm happy to field questions from the audience.
Thank you so much, Mike. So I'm going to pull us all the way back to some basic concepts that I think many of us, some of us, I guess, kind of ignore. When it's been a little while, but as a pediatric practitioner, one of the issues I think we have maybe shied away from is using actual body weight of children versus taking the time to actually figure out the ideal body weight. So that's something that I think as a pediatric practitioner we have a little bit of a challenge with initially, right? And so here we have this issue with using actual body weight versus ideal body weight. And over the years, again, it's been a little while since I've pediatric bedside, but over the years, I think we've gotten a better job. We've done a better job of getting to that ideal body weight. So my question first is, getting into the practice of using ideal body weight can be a challenge for a practitioner depending on their training and what other experiences that they've had.
Absolutely.
So at the bedside, maintaining infection control practices, not using measuring tapes that are common to patients, and so on and so forth. Are there any initial tips we can give our practitioners who are maybe new to the pediatric world or are thinking about going to the pediatric world or simply don't think about the pediatric world to get into that, get into the swing of things, so to speak?
Absolutely, and I think, and just to jump back to this slide, that again, it is recommended, but you're right. There are centers that don't do it in pediatrics, and it's hard to get into the habit of something, especially as you pointed out with concerns about infection control and other issues. A lot of centers now have switched to really trying to make it as seamless as possible to get ideal body weight from your patient at the moment you put them on the ventilator. So some centers, I'm a firm believer in sort of mise en place, if you will, the French cooking method, but the idea of having all of the tools that you would need in order to do this every time ready every time. So, at my center, for instance, we have paper rulers that are folded up that are in the start kit for every ventilator that is prepared to be used in the sterile ventilator kit. So having all the tools, I think, is necessary, but also just reminders. It's not a very hard thing to do, but having reminders that this is something you need to do, especially if you haven't been in the habit of doing it, it is really helpful. At our institution, we hang signs on the ventilator. We have equipment on the ventilator. If I had my way, we'd have a prompt in the ventilator software, but there's not a way to do that. necessarily. But yeah, I think the big thing is just making it simple and having frequent reminders. In pediatrics, the other thing that is trickier than adults is that kids tend to be a little squirmy, right? So they can be hard to get a measurement on, and since they're small, an inch can make a big difference between the length of a child. So working on having a standardized technique for doing it is also, I think, really important in order to get into the habit of doing this and doing it well.
And I think another issue is, one of the limitations you identified was that they didn't have patients under 2 years of age in this particular study. But I also think that many of us consider, oh, they're tiny, I'm going to use some sort of a pressure ventilation. I don't need to deal with an ideal body weight. But that's not true when we're looking at targeting specific tidal volumes, yeah?
Absolutely. I think that's completely and totally true. And that is a thing that's worth pointing out. I'm going to flip back to this slide that shows this. But, one way to look at this data is to say, wow, the lighter patients, the patients on the left hand there, on the left-hand side of the scale there, don't differ very much from their actual weight. Therefore, is it really that important? But some of these data points really do, and that's the thing, is it's hard to tell when looking at your patient whether their actual weight or their ideal body weight are going to be different. The only way to make sure that you don't end up over or under ventilating your specific patient is to measure them. And yeah, I mean, cutting off at age 2 is difficult because we don't have that data. And although if this indicates anything, it's that there's probably going to be less extreme differences between actual body weight and ideal body weight, it still definitely is something that should be measured. And whether you're using, again, pressure-targeted ventilation or volume, you still want to be maintaining accurate tidal volumes delivered and based on ideal body weight, regardless of the style and mode of ventilation you're using.
So again, I'm focusing on limitations. One of the things that could make this a stronger study and therefore have more clinical impact is to increase the number of centers that we use, increase the number of ICUs, maybe have some standardized training for our respiratory therapists who are setting these things. But I think that the main point then is we still need to use ideal body weight.
Absolutely. I think that is the main takeaway from here, right, is we need to use ideal body weight. Regardless of the patient population, we need to use it. And again, the nice thing here is you don't need to get hung up on which method your institution wants to use. If you're using one of these 3 methods, they all are pretty reliable. But yeah, we need to use it as a takeaway. And definitely, we need to increase, it'll be very good to see this study increased. I have heard some rumblings through the grapevine that is in the works with some other groups, which would be nice. But it would also be interesting to see that obviously is not the job of these authors, but it would be interesting to see a poll of what centers are diligent about doing ideal body weight even in pediatrics and which are not. And I don't know the answer to that, but I think that would be an interesting follow-up study to have as well.
So another issue to remind ourselves is that these authors evaluated 3 different methods. And the good news is the 3 methods were fairly equal. So is the take-home point, it doesn't matter which one you use as long as you use one of them?
I would say that with these 3, obviously I can't comment on other methods, and there are other methods. But within these 3, the data currently, again, with this set of 58 patients above age 2 in one ICU, does say that it doesn't really matter which one you use, which is good. Again, I think that anything that makes it easier to perform good practice is a good thing, right? So I think that is a definite strength. Oh, I feel like there was another half of your question that I've lost. But yeah, it doesn't matter which method you are using. Oh, this is what I was going to say. The tricky part, and this is one thing I like about this this manuscript really trying to emphasize the importance of doing this, is that it is also more difficult to do ideal body weight on pediatrics than it is on adults. That on adults you have these small tables that are linear and based on height, but many of these ideal body weight methods, including the three proposed here, weren't really designed for kids. So you have to do several extra steps to get there. You have to involve a growth chart. You have to have percentiles of height and weight depending on which method you use, and that is that is unfortunate, but it's harder to predict because kids have more variation in their size and they grow at different rates, right? An interesting thing that's not discussed here is particularly in the NICU and the younger side of the PICU is that patients grow while they're in the hospital. So the importance of continuing to track ideal body weight is not addressed in this manuscript, but I think is another thing that would be important, is we can't just leave patients on the same ventilator setting as they are growing.
And then we haven't taken into account any of the lung diseases that would decrease the child's lung volumes. So with these particular disease processes, unless I misread the article, none of the patients involved in this study had any issue with hypoplasia or anything like that that we would have needed to take into account.
Right, and that is, I flipped back to this slide here from the publication last year from the Pediatric Acute Lung Injury group. But that is correct, that although they didn't report no lung hypoplasia, the fact that they were excluding, scoliosis and congenital heart disease typically excludes these other syndromes as well. And that is something to keep in mind, is that there are going to be outliers from even the ideal body weight, that if you have a patient with a lung hypoplasia syndrome, then it is certainly reasonable to consider deviating from following ideal body weight. But as a general practice, I think ideal body weight, it's safe to say ideal body weight calculation for targeting tidal volumes is best practice.
One of the attendee questions is about the ideal body weight from gender and height with our adults. Do we have enough spirometric data to really look at those kinds of studies for children?
And it's a great question. And to my knowledge, the answer right now is no. The authors talk a little bit about this in the manuscript, but don't go into great detail. But that is an issue, right? Is these values, we can use the growth charts and whatnot for different sexes, but we really don't have the spirometric data yet in children to have a great range, especially when they get even younger. That older kids we get more and more data from, but we don't necessarily have strong data about lung size based on spirometry in these populations. So that is a drawback to trying to guess pediatric lung size.
And I think it's important that we have to remember how vulnerable these kiddos can be. And this is just a starting point, right? This isn't where we're going to end up, and it's not the end-all, be-all. But after we've set our initial tidal volume or pressures to achieve a certain tidal volume or whatever, our focus is on maintaining a tidal volume that's appropriate based on the feedback that the child provides us with blood gases, chest x-rays, and vital signs and such.
Right. I'm sorry, I think you might have broken up on my end. Was there a question there, Shauna?
There wasn't. It was more of a, no question, just me hypothesizing here.
Yeah, no, I think that's exactly right.
Yeah, I think that part of the frustrating piece is coming into maybe the middle point of a patient's trajectory in the ICU and hearing, oh, well, the patient is, has X percent or X pounds of ideal body weight, therefore the tidal volume should be here, instead of looking at clinical data to make sure that we're providing the child with the appropriate tidal volume after it's already been established and we've gotten clinical indicators about whether or not that information has come through.
No, exactly. I think that's completely and totally accurate. And again, we're getting more and more, technology is providing us with more and more metrics for evaluating lung volume in real time. Some ventilators can provide basically full total lung capacity in real time. You have electric impedance tomography that can try to show actual airway recruitment and lung recruitment. And all of those techniques, in order to maximize alveolar recruitment in ARDS and other airway diseases, tend to deviate from this ideal body weight tidal volume idea for guiding ventilation. And that is going to, I think that is going to provide more and more areas of debate as we have more techniques for monitoring real-time lung size and ventilation. And that is just a thing to remember, is that ARDSNet, which is where a lot of these recommendations either came from or their more strong suggestion came from, the two of the things that were shown to improve mortality in ARDS reduced, right, airway recruitment. So lower tidal volumes inherently don't necessarily help lung recruitment, which are what a lot of our techniques do. And so that, and lower PEEP. So that is something just to think about, that ideal body weight. I think this is a good metric for where to start, but I think that it definitely needs to be taken in consideration along with the rest of the clinical picture and the other markers of appropriate ventilation that we have.
Thank you so much, Mike. I've really enjoyed this session, and I think that there's so many core principles that have come out of this article that we can take back to the bedside and provide better patient care for our pediatric kiddos.
I completely agree, and it's been my pleasure. I really appreciate the opportunity to present this.
And thank you for everyone who joined us today. Please join us again on, let me get the slide up. We'll come back on October 3rd with Dr. Robert Joyner, who will discuss an expanded scope of practice. And we'll be back with our next journal cast on Friday, October 19th. Thank you again, and have a great day.
Bye, everybody.
That is all the time